Hey there, my name is Weakness Perfect on Reddit. I am a rising PGY-2 Internal Medicine resident, and I wanted to create this guide for incoming PGY-1s or interns, particularly in internal medicine residency, although I've been told that other specialties can also benefit from this. If you are watching this, you're probably terrified about starting residency, but also kind of excited, and that's okay. I made this guide because I remember how it felt to walk around on my first day of residency, not knowing what to do or what to expect, and kind of just winging it until October even. And that's kind of when I fell into place. I think starting off knowing what to expect makes you a stronger intern right off the bat. So that's kind of the goal for this video today. It's just, a guide to help you with your first day. So we're going to be covering several topics today, including just what to expect from orientation, what your expectations are throughout the year, what your daily workflow will look like, how to make clinical decisions, and just some important things that you need to know right off the bat, how to be a better team player and communicator, and just, how to take care of yourself long term. If you stick around long enough, I do have a section dedicated for international medical graduates. I am a IMG myself, so I know how tough the transition is, coming into a new system. So yeah, the last part of the video is kind of dedicated to my fellow IMGs, just so that we can make the process as smooth as possible for you guys. So getting started, what is residency? What is your job? What is the role? What is the purpose? And it's basically to just absorb knowledge. You are there to learn. You have a wonderful medical background. You have all the knowledge, and you're here because you belong. This is your calling. This is what you're meant to do. You will improve as time comes, so don't be discouraged. You may make a lot of mistakes in the beginning, and that's okay. You have your seniors to rely on. You have your attendings. You have a lot of people that are kind of looking over you just to make sure that you are making the correct decisions and you are developing your clinical judgment. So just kind of relax. We can take it day by day. It's going to be okay. So starting off strong with orientation week, most programs have implemented this 1 week prior to July 1st. So the goal of the orientation week is to kind of meet everyone in the hospital. So you'll probably be meeting your program director and assistant program director, obviously, and your program coordinator. But you're also probably going to be meeting the higher ups in the hospital, the C-suite, and some other consultants maybe, and some other attendings maybe. The biggest goal of orientation week is to kind of figure out all the new faces. So you are going to have a lot of co-interns, seniors. You're going to be introduced to the pharmacy team, the nursing coordinators, the care coordination teams. You're basically going to be introduced to all the major groups that you will work with in residency. So that's great. It's very overwhelming meeting new people. No, you do not have to remember all their names right off the bat. But yeah, get to know people, explore, talk to new people as you see fit. Introduce yourselves to the staff. It's a good time to just get your name out there, and just enjoy the vibes. You will also have EMR training during the orientation week, along with other trainings, so just CPR training, and just basic things that you need to know as an intern. But I think the EMR training day may be valuable to orient yourself to a new medical records system, but it may not be the all-encompassing tour that you would need. So I had 1 day maybe like one class in the morning, and it finished up by early afternoon, of just like of this EMR training on Epic. And granted, Epic is already very intuitive, but I haven't really worked with it as much, so it was very overwhelming, but you kind of learn as you go. You will learn more on the job than in like the actual EMR training day, but it is still important to kind of orient yourself, like I said. The third thing that maybe implemented in orientation week are like social events. I know that like my program specifically does like picnics and like these mixers, and then just like a dinner, I think one of the nights, just, you know, to meet the residents outside of like a hospital setting, just to get to know them more on a personal basis. And I think that really helped me like kind of find out more about my like intern class, but also more about like the program leadership and the seniors, and just kind of like what to expect on day one. I did not start on the medicine service. I started my intern year off on a rotation. So that's why my year looked a little bit different. But if you are starting off on a medicine service, this would be like a great time to ask them about like expectations and such as well, in like a more informal setting. So they'd probably help guide you a little bit more. Most of orientation week may include lunches, or breakfast even, but reach out to your program coordinator to confirm this if they haven't done so already. Don't quote me on this. My program does offer like breakfast and lunch during orientation week. So how do you survive week one? It's going to be the hardest week in your entire medical career. You are responsible for many things that you didn't know you were going to be responsible for, but at the same time, everyone around you knows how hard the transition is. So they will not judge you based on your performance on week one. You aren't going to be awkward. You're not going to know the answers. You probably won't even finish like all the tasks that are assigned to you, and that's okay. You don't have to be perfect. You just have to be able to be teachable. So that's all that we're looking for. But you know, like honestly, the most important part, what you're going to do in your first week is figure out your daily workflow. So we can talk about like the actual workflow later, but I want you to focus on, where am I going to park? Where is the resident lounge? Where are the wards? Where's the cafeteria? Where are the elevators? Where are the stairs? So your logistics, like how are you going to move around the hospital? Where are you supposed to be at any given point of time during the day? So and like, you know, where is the bathroom? So these are like very important parts of your day that I think you should kind of like figure out early on in the year, or, you know, rather like during orientation week or your first week on. You should also probably make friends with some of the seniors. They're going to be doing a lot of the heavy lifting during your first week. So they are responsible for the entire list of patients. So they're likely not going to be dividing, you know, all the patients with you and like another intern or whatever. They're probably going to be taking the brunt of the work. You know, whether it's like answering pages or doing admissions, doing discharges, seeing the sick patients, you know, they just don't want to overwhelm you on day one. So make friends with them. Be comfortable telling them how comfortable or uncomfortable you feel. So if you feel comfortable taking 3 patients, wonderful. If you would rather have 4 or 5 patients, let them know. Just, you know, communicate as much as possible with your seniors. If, you know, if you're feeling overwhelmed or if you're feeling underwhelmed or if you want to do more or less, you know, it's really good to develop a relationship with them, just so that you can build a little bit more trust with the senior. And, you know, next time you're working together, they'll let you do a little bit more and then a little bit more. And then that's kind of how you grow and develop. So, or develop a relationship with the seniors early on. And also, like, embrace the awkwardness. Just, it's okay. It's going to be awkward. It's awkward for everyone. It's not going to be the best week of your life, but it's going to get better. You will understand how to do the tasks. You will understand what is expected of you. You will kind of pick up the pace. You know, that's what got you so far, right? So now we're going to talk about like what to wear. So to orientation, I would recommend wearing like business casual. So that's for my ladies, like dress pants, a polo or a blouse with some closed-toed shoes. And for my men, that would again be like dress pants with a button-down shirt tucked in. You can wear a tie if you would like. If you are in the clinic setting, things get more casual by Friday. My clinic really does bend the rules of the business casual attire, and I love that about our clinic. So it just depends based on your program culture. While you're inpatient, you're going to want to wear scrubs, but you're going to figure out if you have a color code in your hospital. My hospital personally does not, other than like the nurses wearing navy blue, so I tend to avoid that color. I do have colorful scrubs. You can go as neon highlighter with your scrubs as you would like. Unless of course you do have like the color code, but some brand recommendations are like Mandala, Figs, Janu. There's a lot of good companies out there. I personally wear a lot of Mandala scrubs just because I find them more comfortable. Or you could just go old school, like, hospital issued scrubs. That's totally fine. No one's judging you here. I would wear comfortable shoes. So whatever is comfortable for you. For me, I found that to be like a combination of my Hokas and my Skechers, just depending on like what type of day I'm having. Those tend to be like my go-to shoes. I know a lot of other people that wear like Nikes, New Balance, and like, the other ones. But again, pick shoes that you can comfortably sit and work and stand and run and walk in for over 12 hours. As for your outerwear, I do recommend like layering up. I think like the hospital, at least my hospital, is very like chilly in some areas and then warm in other areas. And I don't know, it's very awkwardly ventilated, I would say. So I always wear something outside on my scrubs, or I wear underscrubs. So for underscrubs, I really like 32 degrees. You can get like a 2-pack at Costco for like, I want to say $10. But our program did provide us with like a residency jacket with our name on it, and that's pretty nice. It has a lot of like pockets and zippers and such. Other popular options are like Patagonia, North Face, Columbia, just whatever works for you, whatever keeps you warm. So here are like the expectations by year. So PGY-1, you're an intern. You are expected to present cases, develop your clinical skills, have good communication, be professional. You want to be a part of the team, and you want to start teaching the med students. PGY-2 and PGY-3, you're seniors. PGY-2 is when you first become a senior, so you're learning how to run the team, manage like all the patients, make all the clinical decisions, oversee the interns and the med students. You're responsible for like more of the dispo planning and the logistics of the admission. And then in your third year, I think like the biggest difference that I've heard my seniors talk about is that that's when you develop your clinical style a little bit more. So you're, more focused on like how you would do things. You are definitely more at ease in your third year. You're also focusing on like board prep, fellowship applications, maybe some last minute QI projects that the program threw out on you. But that's another tip that I have. Like if you do have like a research or QI obligation at your program, find out about it early. You don't want to be scrambling in June of your third year, like some of my seniors did. So I think like here, the biggest thing to remember as an intern is that if you're being overseen during like your medicine days by a PGY-2, they may like micromanage your work a little bit more just because it is the first time that they are seniors, so they don't have as much practice with it, and you just got to be okay with it. It's just their way of reassuring themselves. PGY-3s, in my opinion, are way more chill, just because they've been doing it longer. They know what to look out for and what to kind of let slide. So just give us PGY-2s a little bit of leeway there. So now we're going to talk about like what your daily workflow is like and how to stay organized. So you're going to figure out like your method of staying organized pretty early on. I will say you may adapt like, organizational styles from the senior that you're working with, like your first block. And if it doesn't work, you can always adapt. You can find some guides online or, just see what other interns and other seniors are doing. My personal method I will be discussing soon, but first I just want to kind of like go over what an inpatient day looks like. So this is only like a framework of a day shift when I would be on call at the hospital that I work at. We also have a short call day that ends at 2:30. And then we have our night shift that starts at 6:30 and ends at 6:30 in the morning. So for me, like a typical day looks like, coming to the hospital at around 6:15, getting set up at the computer, wiping down my station with a cloth. And then at 6:30, I do receive sign out from the night shift. I chart review my patients, and then I prepare for rounds with my attending. We can either do table rounds or walking rounds. And table rounds are basically when you're still at the computer, sitting around a table with the attending, and then we kind of go over each patient. You would present to the attending each patient, and then the advantage of that is you have the time to actually discuss and learn about each patient and also put in orders. Walking rounds are not my favorite, I'm going to be honest with you, but what you would do on walking rounds is walk to each patient's room, present the patient outside of the room, and then go see the patient together. You could have like a WOW, which is basically a workstation on wheels, where like you can place orders right away. But for the most part, most of your orders will be placed later on. So after you come back from rounds, it's typically 11:30. You're going to want to prioritize consults, orders, discharges, and admissions, and then your notes. So the notes should be the last thing that you do in the day after you put in all the consults and the orders and the discharges. So why is that? So like, why do we prioritize it in that way? So the consults, you want to have your consults in very early in the morning so that the consultants are notified of the consult and they have time to review and see the patient before the end of the day. As for the orders, obviously the management of each patient changes based on the orders. So you want those pretty early in the day as well, right? As for the discharges, you want to get patients out of here. And admits, you don't want them to keep waiting in the emergency department for too long. You want to actually start the treatment. So that's why we prioritize that. And then like the notes are honestly the least important part of a clinical workflow, but the most important part because documentation is everything. But again, like this is how I would prioritize your day. Around 12 o'clock is when our program does lunch and a lecture. We don't obviously have lunch every day provided to us, but we do have that hour to eat our lunch that we either bring or buy at the cafeteria. And some programs do an entire day of lectures. Some programs do like morning report. This is just the way that my program does it. Around 3 p.m., we run the list with the attending. I put RTL because you will see this quite often, and I did not know what this was, but basically it's when the attending circles back with you in the afternoon just to kind of go over all, like, the tasks during the day. Like, what did, orthopedics say about the little old lady that fell and broke her arm? Or what did the neurologist say about the stroke patient, So you kind of go over like lab results and imaging results that you may have ordered earlier in the day, or if you made any medication changes. Let's say you made a change to like a blood pressure medication, you can like review the blood pressure, basically all the like pertinent stuff of what you changed earlier in the morning. You kind of just review it with the attending in the afternoon. We continue to take admissions, and then we sign out to the night team at 6:30. So now that you kind of get like the workflow of a typical day, this is kind of like the workflow of an admission. So this works for admissions that you receive overnight from the night team, and then you're like reviewing the patient in the morning, or admissions that you're getting throughout the day. So this is my order. So first I will check the vitals. what are the vitals on admission? What are the vitals now? Or like, what are the vitals when they first came in the emergency department? What are the vitals now? Did the emergency department do their job and stabilize the patient? If the patient's blood pressure is too low, let's say it's like 60/40, I am not even going to bother looking at anything until I get a repeat blood pressure and I go see the patient. That is your priority. Why is this patient's blood pressure so low, right? If it is that low and it's not getting better despite any like interventions, that patient needs to go to the ICU. You are not accepting that patient for admission. You are not going to review the patient further if this is like an overnight admission, right? So this is your most important part. And then you will check labs and, write down any lab values that are pertinent only, right? So let's say they have a hyponatremia and then like hyperkalemia and then elevated creatinine. And you just, basically you kind of go through it. I usually do it based on how Epic presents it to me. So I do the RFP and then I do the CBC. And then there's like other labs that I look at if they've been ordered. So the important part of reviewing labs is it helps you come to a diagnosis and it helps you build your problem list later on when you're writing your note. And I'll touch base on that in a little bit. Next, you're going to want to see the past medical history. So this is not only the past medical history, but you're going to also look at, previous admissions. You're going to look at like outpatient records, if they have any specialists that they follow with. And you're going to look at culture data, especially if they're here for another infection. So let's say you have a patient that gets recurrent UTIs. You are going to check the culture data from a previous admission to help you target the antibiotics that you're going to be using on this admission. So that is why it's so important to know what grew in their specimen previously and what it was susceptible to. So let's say they had grown a vancomycin-resistant enterococcus. So now you know that you cannot give this patient vancomycin. You would need to broaden your antibiotic coverage. So that's why it's important. Next, I usually review the emergency department note just to kind of see what they did in the ED and what their thought process was. And then I review the H&P. I also, at this time, will review any like imaging, and also any like EKG that may have been taken, just because I want to get like a better baseline, and I don't want to rely solely on the H&P. So I'm going to touch base on it a little bit later, but like when you're writing the H&P, you do have a portion called the ED course. And so the purpose of this is to quickly review any like information from the ED and just have a quick overview of as to what's going on with the patient. So I would typically say, let's say the patient came in for like a pneumonia. So the ED course would say, under imaging, it would say chest x-ray suggestive of left lower lobe pneumonia. But at this time, I would want to go to the actual image, open it up, and look at the image yourself. So this serves two purposes. One, you get better at reading images and you actually know what you're looking for because you're comparing the radiologist's report to what you're seeing on the image. And then two, you may even find something that the radiologist or the night shift resident might have missed. So that's why it's like really important to actually look at your own images. Next, you're going to review the orders that were placed overnight. And then from there, you're going to think about what you're going to do for the patient today. So are you going to stay the course and just continue the same treatment, or are you going to add anything? Are you going to make it, change the antibiotics, change the rate of the fluids, add a consultant, whatever it may be, right? That's when you're going to start thinking about those things. Okay, so next I'm going to talk about SOAP presentations. If you are a U.S. medical student, now incoming resident, this is something that you're very familiar with. A lot of IMGs outside of the Caribbean, at least, are not very well versed in soap presentations. It took me a long time to learn this, so I did kind of prepare before residency started because I knew that this was an expectation, but I didn't really have it down until I want to say October. So if possible, this is something that I would prepare extensively prior to joining residency, just because your day one expectation is that you know how to do a soap presentation. So that is something that you need to know on your first day. Just a quick overview. So the SOAP presentation stands for Subjective, Objective, Assessment, and Plan. So what is subjective data? So subjective data is something that the patient tells you. And this is also where you would include the history of present illness. So when you are presenting an old patient to the attending, you're going to first talk about overnight events. Then you're going to talk about how the patient feels this morning. Then you're going to go into objective data, which are basically facts. So what are the vitals? What is your physical exam? What labs were pertinent? You're not going to list all of the labs, only the pertinent labs. What are the ins and outs? And what are any new imaging findings? Then you're going to go to your assessment, and this is basically 1 to 2 sentence summary of how the patient is doing or what they're here for. And then you're going to go into your plan, and this is listed by problem in order of importance. And you're also going to talk about chronic problems here. So if I were to do an example, a quick example, let's say I have a patient who has type 2 diabetes and has frequent diabetic foot ulcers. Now, status post a 5th digit amputation following a diagnosis of osteomyelitis. So how would I present this patient that is now coming in for worsening discharge from that previous wound? How would I present this patient? So first I would talk about the overnight events. So overnight, the patient did sustain a fall. This was when he was walking towards the bathroom. He lost balance and hit his knee. However, there was no effusion or tenderness or concern for fracture at this time, and no imaging was taken. He did receive a dose of Tylenol for pain, and that's it, right? That's the overnight part. Then you would talk about this morning. Then you would say, this morning, the patient says that his knee pain has subsided. He does have some tenderness over his right foot. The drainage is worsening, but he has not spiked any fevers, denies any urinary retention. And then you would just kind of keep going based on that, right? You would just expand on your review of systems as such. Then you would go to your objective data. He is vitally stable. Physical exam reveals purulent drainage at the 5th metatarsal stump and at the 4th digit as well. The rest of the physical exam is normal. Heart and lungs are clear. No flank tenderness or abdominal pain. Then you would go to labs. Creatinine is elevated at 4.51. Sodium, he has mild hyponatremia at 130. The potassium, he is hyperkalemic at 5.8. Ins and outs wise, he has a negative 80 ml with about 500 cc's out since last night. And then for your assessment and plan, So this is a 67-year-old male with a past medical history of type 2 diabetes mellitus, presenting with 5th metatarsal stump drainage and new 4th digit ulcer, and found to have osteomyelitis of the 5th, 4th, and 3rd metatarsals. Podiatry was consulted, and they recommend TMA, which will be performed tomorrow afternoon. For the plan, you would go by problem. So what is the first problem? Our first problem would be the osteomyelitis. So you would kind of go into depth about it. What toe is it on? Has he had like an operation on this before? Has he had antibiotics in the past? Things like that. What antibiotics was he given in the ED? Who was consulted from podiatry? And then you would go to your plan. So in your plan, that's when you would talk about, okay, I want to continue vancomycin and Zosyn for broad spectrum coverage. Dr. Podiatry was consulted and recommended, and TMA that will be performed tomorrow. He is to be made NPO at midnight tonight. And for pain, we can give him scheduled Tylenol with oxycodone for breakthrough. And then once he's made NPO, he can get IV Dilaudid. The next problem would be the AKI. This is a new problem for him. He does have a history of CKD 3A, but his creatinine at baseline is usually 1.17. Today it is 4. Whatever I said before. But so for him, I would like to consult nephrology to discuss options in case he does require dialysis in the future, right? And then you would go to the next problem, which would be his diabetes. That is something that we're going to be managing in the hospital, even though it's a chronic problem. And then you would talk more about the diabetes. So what are you going to do? You're going to hold home metformin. You're going to put him on sliding scale, maybe sliding scale 2, since he is a diabetic. And you want to check an H1C, a hemoglobin A1C, just to give us a baseline to see if his diabetes is well controlled or not, right? So these are just kind of like how you would walk through the SOAP format. I know I was kind of slow with it. I just wanted to enunciate each and every portion. When you're doing like a new admission, you would kind of start with the full H&P with like, your entire like history of present illness, and then like your ED course, past medical history, allergies, medication list, social history, and then you would talk about the overnight events, how they feel this morning, and then all your objective data, and then the full assessment and plan. So the biggest tip that I can give anyone here, regardless if you're a US medical student or an IMG, is to not analyze in the objective portion. So you at most can say mild hyponatremia or elevated creatinine at, or he has an AKI with a creatinine of, that's like at most what you can say. You are not going to speculate as to why. So let's say his potassium was 2.8. You are not going to say, oh, I think his potassium is low because of XYZ reasons. No, you're just going to say he has mild or moderate, whatever. Okay. The assessment and plan portion is when you talk things through. You make a differential. What are you thinking about? Why do you think, each lab value is high or low? What are you going to do about this problem? That's when you would like speculate. But before that, in the objective portion, you're just spitting facts. Okay, moving right along, I'm going to talk about how to do an effective sign out. So I see a lot of sign outs from, sometimes like my co-interns, or let's say a medical student that had access to the sign out portion in Epic. So I see a lot of sign outs like, check RFP at 8. What do you want me to do with that? Okay, I checked it. I see a lot of abnormalities. What do you want me to do, right? I mean, obviously, if the K is low, they're going to replete it. But an effective way to sign out is to say, check RFP at 8 p.m., replete K as needed. So what you're doing here is you're taking the mental load off of the night team. And that is your job during sign out. You tell them exactly what you want them to do. So the next thing is, like, let's say, you have a patient that's sundowning, and you had discussed with your attending earlier in the afternoon when you're running the list, and you identified this as a problem, and you were spitballing ideas as to like what they wanted the patient to receive if they were sundowning. So this is the plan that you came up with. So try redirection first. If this doesn't work, can give 1 dose of Zyprexa. So you have to be specific. Just don't say like, whatever class of drug. Specify what drug you want them to give. It takes so much mental load off of the night team. They don't need to guess as to like what the attending's preference is or what your preference is. They're just going to listen to you, right? So that's how you do like an effective sign out. You just be very specific. When you're signing up patients in the morning, so you're on nights and you're signing out in the morning, you really want to talk through the overnight events that occurred, just because it's the easiest way for it to actually stick. I wouldn't, be vague about it. Just don't say like they spiked a fever or they went into AFib. No, talk about what you did. Like if you were with a patient for more than like 20 minutes, write a significant event note overnight, talking about what you spoke about with the patient, just to keep everyone on the same page. It's totally fine. You are allowed to do that. And in the morning, just kind of direct their attention to that significant event note, just point it out and make sure that they're aware that it exists, I should say. The next thing that you're going to do is, let's say you talk to a specific consultant. I would tell the day team, like, hey, I spoke with Dr. Cardiology regarding this patient's weird EKG findings. Just letting you guys know so that you can follow up with them later on in the day. So that's just one example. Let's say there was like a non-emergent need for a consult. So let's say you wanted to consult nephrology, but we didn't really need it at the time. Don't do it. It's okay. You don't need to consult them. Just defer to day team, right? You can just say, hey, I think that we might need to get nephrology on board for this patient, but I'm going to leave it up to you guys to decide. That's totally fine. But if it is like an emergent consult, like let's say this patient has a STEMI, you are calling code STEMI, you are calling the interventional cardiologist, right? So just kind of like, you have to kind of figure out like when to put in the consult and when to not. And I think that this is very like hospital specific as well, but with the program culture and like with our hospital culture, this is kind of how we do it. Okay, so now that you know about like the actual workflow, what are some helpful apps that you can use? So obviously when we're doing admissions, I think the apps that I use the most are UpToDate and Open Evidence and MD Calc. So UpToDate, let's say I have like a patient with a very weird presentation or a diagnosis that I don't really know much about. I will read up on that like right at the time of admission just to help guide my management. When do I use Open Evidence? So Open Evidence is great because it pulls in data from actual articles, in case you didn't know. So it is very clinically relevant and it will give you more like pinpoint answers than UpToDate. UpToDate also has its own AI thing now, but I haven't really explored it much. I'm not sure what it's called, but look into that as well. But I really like Open Evidence for this reason, just because I can say, hey, how much fluids should I give this patient with pancreatitis? And it'll say per waterfall trial, moderate amount of fluids is better than blasting them with fluids, for example. So yeah, that's why Open Evidence is great. MD Calc is amazing because I use it to calculate like the NIH score, the FINA, CRIB 65, Wells criteria, just like all of these scores that we use in our day-to-day life, right? It's great because it will give you like the actual like risk percentage, and that's usually what I use it for my risk stratification portion of the assessment and plan, when I'm writing a note. So that's what it's great for. I also use it for pretty basic stuff, I'm not gonna lie, like even like lights criteria, just because it helps me take like the mental load off. A lot of people use it to calculate an anion gap. Even that is in my brain very easy to calculate, so I don't bother with MD Calc for that. But like there are like multiple scores that you can find on there that are very clinically important. Another study resource is MixApp. It is often provided by your program, and it's good for like active learning. It gives like pretty in-depth like reasoning for the answers for each question. So I think it's like a great resource. Granted, did I get through a lot of my MixApp? No, I'm about 30% of the way in, but that's okay. I still have time before I think about like board prep and things like that. So anyways, okay. So now you know about your workflow. We're going to go into our next unit, which is clinical decisions and patient care. I'm just going to kind of cover like the basics, like what topics you should cover before residency begins. And then just, day-to-day tasks that we do that, you would need to know during patient care. Okay. So the first thing that you're going to look at is a slide where I kind of list out some basic topics to study for not for step one, I'm sorry, to study before your first day of residency. So it's like hyponatremia, AKI, how to interpret like a BNP, atrial fibrillation, heart blocks, EKGs. You want to know about how to treat like a COPD exacerbation. You're going to want to know like your SIRS criteria, what's a CWAL, what's a COWS, what's a curb 65, what are like some antibiotics that cover for MRSA, gram-negative, gram-positive, Pseudomonas. You're going to want to know your stroke scale. So these are just kind of some topics to look over. I'm not going to get into too much depth right now. Oh, and also you're going to want to know like your ABG interpretation. So like your metabolic acidosis, respiratory alkalosis, things like that as well. Okay. So I think this was one of the scariest things for me as an intern. So what do I do at a rapid response, right? Now as a second year, I've had a lot of practice with this, and I've had seniors that push me to run rapid responses from kind of the get-go. I think like outside of the first month of residency, they were pretty good at, letting me run the rapids on my own. So, what are you going to do? So you're going to get a page, and it's going to say rapid response. At my hospital, we do an overhead page as well. You're going to run up the stairs as you're running or walking up the stairs. It's okay. You're going to review the patient. So what room number are they at? So you open it up on your phone. You kind of look through their latest vitals, their latest labs, their latest, ejection fraction, because that's important in case they need fluids, and then just like why they're here in the hospital and what you can do for them. You're going to do this to kind of make an assumption as to what's going on. So you just want to set yourself up for success there. So like, let's say they do have a history of AFib. So you're going to kind of go through your mind. So, okay, I'm going to start with fluids. If they don't respond to fluids, I'm going to give them some metope. And then if they don't respond to metope, what else am I going to do? So you're going to kind of go through that, right? So when you go there, you first ask the nurse what happened. Get the vitals, get a BP, a heart rate, a temp, a respiratory rate, and also get a glucose, because that's important as well. You're going to then talk to the patient, ask them how they're feeling. If they're unresponsive, directly go for the trap squeeze. Don't do a sternal rub. Sternal rub is not going to get you anywhere with a lot of these patients. Trap squeeze is where it's at to get them to actually respond to you if they're unresponsive. Once you talk with the patient, do like a quick physical. You can gather some more like past medical history from the nurses. They'll be able to provide more context, like if the patient is being treated for like an AKI or an infection, or if they have a history of this happening to them, the nurses probably know the patient a little bit more than you do, unless that patient, it does belong to your service. Then you are going to place orders calmly. If you have anyone to delegate this task to, then you would, but ideally, like, what would happen is, like, at least in the beginning, the seniors are going to be the one kind of managing the patient, and they're probably going to ask you to put the orders in. That's what happened to me. Later on, I started delegating that task back to my seniors because they would let me run it, and they would say, don't worry about it, the orders, I can handle the orders. So what are you going to put in? Let's say you really don't know what's going wrong with the patient. You're going to do a rainbow draw. So a rainbow draw is nothing but like a CBC, a CMP, a lactate, troponin, ABG, and then maybe some sort of imaging. And you're going to verbalize this. You're not just going to quietly put in the orders so that the nurses can gather the correct equipment right away. So let's say you want to give the patient fluids, or let's say you need to get like a stat chest x-ray. You are going to tell the nurses this so that they can call the appropriate people and they can get the appropriate supplies so that there is no delay in patient care. If the patient is talking to you, even if they're kind of like decompensating, but they're still talking to you, you are going to explain to the patient what you're doing for them. And this does two things. It calms the patient down and it calms everyone else in the room down, including yourself, because you are revising the plan. And you are talking in if and but statements. So basically, if this happens, great. But if this happens, this is what we're going to do. So you have like a plan A and a plan B, maybe even a plan C. Once the patient is stabilized, or you have a plan in place for the patient, or let's say the rapid has ended and there's nothing else for you to do for the patient, or the patient has been upgraded to the ICU after you spoke to the ICU attending, you are going to write a significant event note. These notes are different per facility, I will be honest. So even at the beginning of the year, they weren't as regulated as they were later on in the year when my chief resident came up with a dot phrase to help us out with like what to include in the significant event note. But essentially, you're going to do like a brief overview of their hospitalization, and then you're going to talk about what you did for the patient. So what were their vitals? What was the physical exam like? What did you do? How did they respond to it? What actions did you take? And what are you going to follow up on? And since you're a resident, what attending was present throughout the duration of the rapid response? And yeah, I forgot to mention that you will always have an attending at the rapid response. At least we do at our hospital. But you will always have someone to kind of bat the ideas off of. So don't feel too afraid. Now, the next thing, electrolyte repletion. What does this mean? It is basically replacing electrolytes. So let's say you walk in, the K for a patient was 3.4, and your senior is like, hey, give this patient some potassium. How much potassium? So let's say your target for that patient was 3.8. You're going to give them 40 milliequivalents of potassium, because every 10 milliequivalents raises the K by 0.1. So how are you going to do this? You can do it via tablets, IV, or packets. So the tablets are like horse pills. They're huge. The IV burns, and then the packets taste bad. So there is like no good solution here. It's just patient preference, unless of course they're NPO or they have like dysphagia. At that point, you would probably choose IV. For magnesium, every gram of mag sulfate raises the magnesium by 0.1. So let's say their mag is 1.4. You give them 2 grams, and then it raises it to 1.6. You can give them IV or oral magnesium. Beware, because the oral magnesium works kind of like a laxative, which is not a bad thing in patients that have like some mild constipation, but just be mindful of that. For your calcium and your phosphorus, you're not going to be doing this on a routine basis, I should say, but you base it off of the ionized calcium for a more accurate repletion. But sometimes, of course, if the normal calcium on the RFP is pretty low, you're just going to straight away give them IV. You can give the IV through like a peripheral IV or a central line, and then the oral is usually just like Tums. So the amount that you give, I can't remember it off the top of my head because I honestly just follow the Epic order set for it. I'm sure most EMRs will have like a similar setup, and same goes for the FOS. You should never forget the FOS so that you can avoid refeeding syndrome. So anyone that has like starvation ketoacidosis or dehydration or like alcoholic slash starvation ketoacidosis, or like any eating disorders, just anyone that hasn't eaten in a while, right? You really want to check their FOS to avoid refeeding syndrome. And then the last thing I want to mention is for cardiac patients, you want to keep the potassium over 4 and the magnesium over 2. There is some new data that's coming out that you don't typically need to do this, but right now I think in most hospitals this is the practice for cardiac patients. Now this is my little insulin guide. So let's say they have a history of type 2 diabetes and they're not on any home insulin, so they're insulin naive. You're going to want to give them either sliding scale 1 or sliding scale 2. And how you decide is usually based on, their glucose levels, their A1C, and your attending's preference. A lot of attendings think that sliding scale 1 does absolutely nothing. And I typically reserve this for patients that have a little bit of hyperglycemia. They may be on like metformin once a day, and their A1C is pretty good. Like let's say it's like 7. So that's the type of patient that I would reserve sliding scale 1 for. Most of their patients, they're getting sliding scale 2. So let's say they are type 2 diabetic on home insulin. So what you're going to do is start them on like 50 to 60% of their home Lantus, just because they're not going to be eating as much in the hospital. And then you can do either sliding scale 2 or sliding scale 3 at meal times. Often if you are going above sliding scale 3, there's something wrong. Like you need to add Lispro at meal times along with the sliding scale. So it'll be like a dose before and a dose after meals, just to cover them, and just to cover them a little bit more during mealtime. So before I talk like about the type 1 diabetic, I can talk more about like the titrating up of insulin. So let's say throughout the day you're monitoring their glucose levels and they required let's say they required like 20 units more than anticipated. So what you're going to do is split the 20 units in half. So half of it goes to the Lantus and then half of it gets divided amongst the meals. So let's say they were already on 10 of Lantus. You would add 10 more to Lantus. So they'd get 20 of Lantus, and then they'd get the sliding scale 2, and then they'd get 3 units per meal, because you're dividing the extra 50 into 3 for each meal, if that makes sense. And then if they're a type 1 diabetic, remember to always keep some sort of basal insulin on board. So keep the Lantus on board, even if they are NPL. Okay, so this is like another very important topic that you should know, even as an intern. So a lot of these code status discussions, your senior will probably take care of earlier on in the year, but you're going to have to know how to do it, because as responsibilities increase over the year, this is something that you're expected to do, and it's a really important part of your job as an internal medicine resident, because you have to know when a patient is more appropriate to be full code versus not, and how to have this discussion with the families. So right now, first I'm going to talk about what a code status is. So code status is basically the patient's wishes for like an emergent event when their heart stops beating, if they would want CPR and, basically being brought back to life. A lot of patients do, and a lot of patients don't. It's just a preference, at the time. So when you're doing admission orders, this is an order that you cannot forget. So let's say the patient decompensates after admission. What are you going to do? Do you know their wishes? Are you going to try to frantically contact family? Like, you really need to know their wishes beforehand in case an emergency occurs during admission. So the way that I do this is at the end, like after I'm done talking with the patient, collecting history, doing a physical exam, and I excuse myself and say, now you're going to head upstairs soon. I'm going to go put in the orders now, but I just have one more question for you. And so then this is the question, how I would do it. So I'd say, one last question that I ask everyone that's being admitted in the hospital. In the emergent event that your heart were to stop beating, I know that this is a morbid question, but just bear with me here. Would you want chest compressions and intubation? You can't have one or the other. If you have chest compressions, you need to be intubated. And they would say, yes, I want both. I want anything that would keep me alive. Then that would be full code. If they say no CPR, no intubation, that would be a DNR, DNI. I think like the actual terms vary based on the state. So I'm not going to get into further detail with that, but there are usually like 2 tiers to the DNR. So there's a DNR comfort care arrest and a DNR comfort care here in the state of Ohio. So a comfort care arrest would mean up until the point of arrest, you do whatever you can to help the patient. But once they arrest, you do not do CPR. You do not intubate. If they are a DNR CC or a DNR comfort care, that's when you would do comfort measures only and just keep the patient comfortable while they're in the hospital. But let's say the patient is 96 years old and they have a million comorbid conditions, and you don't think that this is the type of patient that would do well with chest compressions. What I usually say is, I'm going to help you make a more informed decision here. So chest compressions would entail me pushing down hard on your ribs until your heart starts beating again. This would cause your ribs to break, and there is no guarantee that your heart would restart. It also includes me putting a pipe down your throat and connecting it to a machine to help you breathe. And this is essentially life support. Is this something that you would want? And then at that time, if they say no, then they're a DNR. Or if at the time they say, well, yeah, I just want to stay alive, then they're a full code, and you're going to respect their wishes. And you are going to revisit that code status discussion later on, if appropriate, during the hospitalization. So let's say if they're just there for a very treatable condition, or if they are there for like placement to a facility, it may be not like worth having like an in-depth code status discussion. But if they are actively dying, or if they have an infection that you don't think they're going to recover from, or are like, their comorbid conditions are catching up to them, and then now they may need like a peg tube or dialysis or whatnot, that's when you would start getting the family involved. You would talk a little bit more with the patient. You would get the palliative care team on board, just to, spend some more time with them and talk to them about the wishes, and just help them be a little bit more realistic with their expectations. Okay, so now we're going to talk a little bit more about communication and working with the team. So one skill that is very important is how you talk to the people around you. In a professional setting, such as a residency program, you have to know who it's okay to joke around with and who it's not okay to joke around with. At the end of the day, your co-residents and your co-interns, they're probably safe to joke around with. And, even some of the nurses, but you really have to practice being professional, even when people around you are not necessarily being professional. So there may be some attendings that talk very colloquially to you, I would say. It's okay. Let them do their thing, and then you do your thing, okay? That's, I think, the biggest skill that you got to learn, because you don't want to blur the boundaries any more than they've already been blurred at that point. So now we're going to talk about how to call a consult. I think this is arguably one of the harder tasks during residency, even as a PGY-2 or like a rising PGY-2. This is something that I am a little bit afraid of, but I've had some great practice with doing this over the last year. So I will say this tip is from one of my emergency medicine resident friends, and also like one of the attendings told me something very similar. So you're going to do kind of like a 3-part deal. So before you call a consult, you really have to narrow down on your question. And then when you're actually calling the consult, you're going to focus on the hook, the one-liner, and the question. So for example, you're going to say, for the hook, let's say, you're going to say, "Good morning, Dr. Lyon. I have a patient today that is presenting with painful hematuria following a urologic procedure performed by you." So what is the one-liner? So now you're going to see he's an 86-year-old male who is on Eliquis, who underwent a cystoscopy 3 days ago, and now he has painful hematuria. His hemoglobin is 6.8, down from 10.2. We are reversing his anticoagulation and giving him a unit of blood. And then now you're going to go into your question. What are your thoughts on CBI? So you are asking your question. So that's basically what you want this urologist to do for this patient. You want them to do CBI, for example. I don't know. So that's what you're going to ask them. So that's how you kind of do it. Let's say it's a cardiologist that you're calling about chest pain. So you're going to say, "Good morning, Dr. Lyon. I have this patient presenting with left-sided chest pain radiating down the left arm. That started about 45 minutes ago and resolved with nitro. He is an 86-year-old male, and then past medical history of diabetes, CAD, previous stents, and a cardiac history in his family. His EKG shows some like ST depressions, and his labs are also significant for a troponin of 10,000. We think that this patient may be having an NSTEMI. What are your recommendations? Do you think he would need a cath? Or would you want us to start heparin?" Simple as that. So you just really got to know what your question is. You can't just say, "Hey, I have a patient. Can you come see him, please?" I know you guys are not going to do that, but just be very specific. So when you're talking with like nurses and when you're talking with families, your please and your thank yous go a long way, especially with the nurses. They're kind of like taking the brunt of the patient care, if you think about it. They have to do all the heavy lifting, like physically and figuratively. But when you're talking with them, just be very cordial. There is also a lot you can learn from the nurses, especially in the beginning. Never, ever forget your training, but also acknowledge that the nurses have been here probably longer than you, and they're looking at the patient like 24/7. So if they think that there is something wrong, don't discount what they're saying. Think about it. Go see the patient if you have to. But just don't, learn when you got to actually draw the boundary and when you just say, "Hey, okay, I'm going to come see the patient," right? So another thing I really wanted to talk about was how to talk to families. So it's best if you explain things at like a 5th grade level. So as low as you can go. If you can go to a 3rd grade level, that's even better. It is confusing because we are so used to using medical terminology that the families may not be aware of. They may not know anything about the patient. Of course, before talking to the families, you have to get consent from the patient and make sure that it is okay to discuss their care with their families. And then, if you are actually calling the family, you really have to go through like a quick checklist or like a quick like identity confirmation sort of deal. So how I do it is I'll say, "Ring, ring," and then I pick up, and then I would say like, Hey, my name is Dr. Weakness Perfect. I'm calling from XYZ Hospital, and I have a non-urgent update about a loved one that you have here. Can you please confirm their name and date of birth? And so at that time, they'll confirm whatever the patient's name and date of birth is. And then that's when you would be like, okay, perfect. So now I can tell you about this patient. And then you would give them like the quick updates about the care and things like that. And then you won't confuse them. Now, what is it to be like? What is it to be like the best resident, right? I feel like that's something that all of us probably have Googled at this point. Like, how do you be a good resident? So the first thing, you show up early enough to review all your patients, early enough to help the seniors with any tasks, care about your learning. So how do you learn? You learn by being curious. And then how do you be curious? You always ask why. So always question everything. Why is this patient's hemoglobin so low? Why did the white count go up? Why did the magnesium drop, right? So you're thinking about each and everything. When you're doing this, like let's say there's a patient that you didn't really know the management of, like let's say you didn't really know about the GDMT drugs. So that's something that you would go read up on at night, just, before you see the patient again in the morning, right? You got to get familiar with what the GDMT medications are, for example, or why we're treating the hyponatremia in a certain way, or why we're treating the hypernatremia in a certain way. So if there's something that you don't really know about, read up on it. Then you really got to be open to feedback. At least in the first 6 months, you are going to be receiving a lot of critical feedback. And I mean this in the best way possible. It is going to be the hardest thing that you hear, but also the most important. So I had attending tell me, that I was lacking confidence in my plan. I had to reflect, and I thought about why that was and what was going wrong, because personally I felt like I knew the patient, but something wasn't translating properly, and that was because I wasn't vocal enough. I was not really talking through my plan in my presentations because I was so focused on getting to like the actual treatment portion instead of talking through my thought process. So once I started doing that, the attendings realized that, okay, I know like what she's thinking about. I understand her thought process. So I can start trusting her judgment a little bit more, right? So that you just have to be open to feedback and learn how to adapt from it. And the next important thing is to follow up on all your tasks. Some tasks may be so tiny and minuscule that you're going to forget about it. Try not to. Try to make a list, have a system in place, follow up on all your tasks. When the attending comes around to run the list in the afternoon, go through each and every task and talk about the outcome of those tasks, right? And lastly, have a personality. Be a nice person to work with. Don't be someone that's just grumpy, Be yourself, but be a little bit more polished and professional. And just, overall good vibes, right? So for, long-term success and well-being, just remember that residency sucks. It does. But it's temporary. It is very hard. There are some days that are gonna kill you. Some days you're just gonna, couch rot and fall asleep out of exhaustion. And that's okay. You deserve to be here. The program liked you. They saw your potential. And now you live up to your potential, right? It's okay. You could get burnt out, but that's why it's important to have a strong support system and, have like a system in place to deal with stress. It's important to use your vacation days. At least in my program, we don't get a payout for not using our vacation days, so I would just use them. Have fun outside of work. Don't just, live to work and work to live, right? Just try to be healthy, eat well, exercise whenever you can. In my first year, at least the first 6 months, I didn't prioritize exercise. And then I started at least trying to incorporate like 20-minute bursts of exercise throughout my days. So that's really helped me not feel sad all the time. It did give me a little bit of a dopamine rush. So learn how to prioritize your well-being. Like I said, this is just some ways that you can avoid burnout. Don't be too critical of yourself. Everyone takes various amount of time to kind of get a hang of things, but I want to say like around 6 months is pretty normal. That is the learning curve, and then you start getting good at things because you know what to look out for, right? You're not going to realize how much you've grown in just a few days. You're going to realize it over the month, and then over the next 2 months, 4 months, 6 months. And then now looking a year back, I can see how much I've grown compared to my first day. So always remember, it's just gonna get better, okay? Okay, so that's pretty much it for the first part of my guide. I do have like a little bonus IMG section in case anyone wants to stick around for that, like any of the United States med students. It will talk a lot about like dispo planning, but otherwise, remember that you got this. Like, honestly, if you master your SOAP presentations on day one, and you think about the plan for your patient and you sound very thoughtful in your presentation, you'll be fine. You just got to follow up on all your tasks, just kind of do your job and keep learning. That's it. Remember, it's okay to feel like an imposter, but like I said, you deserve this, you belong here, and you're gonna do great. Okay, so here's a little bonus section for my IMGs. I trained in India, so a lot of this may be compared to how it is in India, but from talking to a lot of my seniors and co-residents that studied abroad, it is very similar, to be honest. So here we go. The biggest difference, I think, is the documentation, the dispo planning, and like how to deal with insurance stuff. So that's what I'm going to be talking about in this portion. So firstly, what is like the biggest difference between residency abroad versus residency in the United States? You are obviously better compensated for your time. Your day does start a little bit earlier, but there is a better work-life balance overall because of the ACGME requirements. A lot of programs are moving away from a 24-hour call structure. So my program does do like night call and then like day shifts. So it really just depends on your program. But again, a lot of programs are moving away from this 24-hour call structure. And there's also protected lecture time. Once again, thanks to ACGME requirements. So, more aspects of like the ACGME requirements is that you need like a certain number of days off in like a certain period of time, but most programs that kind of equates to 1 day off per week, unless you're on like a busy schedule. But yeah, it's pretty great. So the hardest part, that I face as an IMG is like documentation. I think like the best thing to do is steal doc phrases from your seniors. It is way more structured than at least I was used to overseas in India. And then you would also think more about like the dispo planning. So a lot of the patients aren't going home straight away. They're going to a skilled nursing facility, an acute rehab facility, or an LTAC, which is a long-term acute care hospital. Sometimes people are going home, but they're going home with certain services like physical therapy. So there's a lot when it comes to discharge planning and stuff. But what basically is going to happen is like for a SNF, which is a skilled nursing facility, patients get about 30 minutes of physical therapy a day. At an acute rehab facility, they get, I think it's like 2 to 3 hours of physical therapy a day. So that's the biggest difference between the two. And LTAC is for patients that are more like trach vent dependent. And then home with physical therapy, occupational therapy, those are for patients that are more like independent. They just need a little bit more ongoing care, right? Unfortunately here, insurance does play a big part in like clinical decision making and documentation. So you really have to be careful about how you document things. The social work team and the transitional coordination care team are your best bet to kind of navigating insurances, because they're the ones that are talking the most with the insurance companies when it comes to discharge planning. You really have to know your local pathology. So here I see a lot of patients that are either very young or very old. So that's just the kind of population that I'm in. Other populations may have more of a middle-aged crowd, right? So it just really depends on like the age, the demographic of your population, the region that they're in, the socioeconomic status. So really know the area, really, you know? And then don't forget that despite the Swiss cheese model, there are a lot of systems to catch mistakes. So let's say you do put in an order that is erroneous. You will have warnings from your EMR system. Your pharmacy team will reach out to you. Your senior may look over it. The nurse may question it. Your attending is ultimately responsible, so they might question it. You are never the one and only person looking at the order. So just remember that. It is okay to make mistakes, but try to limit them when it comes to orders, because your mistake may not be caught in time. But just remember that there are always people that are going to be questioning your orders, okay? So another thing that I really want to discuss is, like, again, the SOAP presentations. A lot of people do find difficulty with SOAP presentations, so I think like practicing out loud, and then using like examples that you find online and really are your best bet to learn how to present. You could also ask like ChatGPT, Claude, about sample cases that you would then practice presenting in a SOAP format, which is what I did initially until I got the hang of things. I would just ask like ChatGPT to create a case for me, and then I would present that case, and then it would give me feedback on it. So that's just what I did. Another thing that I wanted to discuss here is about like how to formulate a plan. So you would start with your most obvious reason for hospitalization, like why did this patient come to the hospital? And then that would be your first problem. And then your next problem would be like all the lab data. So let's say that's when you would start with like the AKI, the hyponatremia, and then you would just list it in order of greatest to least importance. And you can even group the problems together. So let's say the AKI is because you think it's like hepatorenal syndrome. So then you can talk about that and then kind of club several problems together into groups that make sense. Never forget to end with like a section that says chronic problems, and then talk about like what you're going to do with each of the medications they're on at home. So for example, their hypertension medications, their like heart failure medications, let's say they're on any blood thinner. So these are all medications that you need to list out and mention if you are going to continue or hold them on admission. Lastly, we have, at least at our hospital, a section called Global Plan of Care. But basically, this is the last section where you would include if the patient is on IV fluids, what kind of diet they're on, if they have any consultants that were consulted, and then their code status, and just a general overview at the end, right? So that's how you come up with the plan portion. I do have a little bit more detail on how to do this and like the physical PDF guide as the rest of this presentation. Just I just really wanted to include this because I know some people understand things a little bit more when they are spoken out to them and, like, you know, they're verbalized. So that's what the purpose of this presentation is. If you are someone that learns more from reading, I do have like an accompanying PDF that I'm going to link down below. So please feel free to check that out. Again, I'm going to say this again. It doesn't matter how many times I say it throughout the video. This is the most important thing. You belong here. You are going to be fine. You're going to do great. Everything that you did, you know, from high school to med school to all the training that you had, this is why. You're finally here. You finally made it. Is it going to suck? Yes. But is it a learning curve? And do I think that you can do it? Absolutely yes. Just, you know, stay organized, learn the system, learn to communicate, ask really good questions, and remember, you belong here. You've earned this. Trust the process. Okay, so I'm glad that we made it to the end of this video. If you have any questions, feel free to message me either on Reddit or Instagram, or email me with any questions that you may have. I'm at Weakness Perfect on all my socials. I also offer personal statement and CV editing services and IV prep services for those of you that are still applying to residency. So if that is something that you're looking for, I make those services very affordable compared to other prices that you find online. So again, please feel free to send me a DM. And I hope, you found value in this video and you have a great rest of your day. Good luck.